this session, I shall be talking about antepartum hemorrhage. I am Professor Odushola Fashuba from the Department of Obstetrics and Gynecology, Obafemi Awolowo University, Ile-Ife. Antepartum hemorrhage is a leading cause of maternal mortality and morbidity in most developing countries. At the end of this lecture, you should know the definition of antepartum hemorrhage, placenta previa, abruptio placenta, and vasa previa. 2, you must be able to list the various causes of antepartum hemorrhage. 3, you must be able to describe the management of placenta previa and also describe the management of abruptio placenta. And you must be able to know how to distinguish vasa previa from placenta previa. These are the learning outcomes of this session. Antepartum hemorrhage is defined as a bleeding from the female genital tract after the age of fetal viability, which is 28 weeks in our environment, but before the onset of labor. Antepartum hemorrhage is defined as bleeding from the female genital tract after the age of fetal viability, which is about 28 weeks in our environment, but before the onset of labor. As I said earlier, obstetric hemorrhage remains a leading cause of maternal morbidity and mortality, and it complicates about 2 to 5% of pregnancies. APH complicates about 2 to 5% of pregnancies. What are the causes of antepartum hemorrhage? The major cause of antepartum hemorrhage is placenta previa, which I will define later on. The second major cause is placenta abruptio. And the third cause, which is very rare, is the vasa previa. There are some local causes that could mimic these first three, that could mimic placenta previa, placenta abruptio, and vasa previa. These local causes could be a vaginal trauma. A trauma to the cervix can cause some degree of bleeding in pregnancy. Then there is cervical ectropion. Cervical ectropion is that situation where the lining of the inner lining of the columnar epithelium, where the columnar epithelium comes to line the ectocervix, and the ectocervix looks velvety and reddish. And where the woman has intercourse in pregnancy, because of the highly hemorrhagic nature of the cervix, she could bleed from cervical ectropion or cervical erosion. Vaginal infection, when vaginal infection occurs, can also give rise to some bleeding episodes. And finally, cervicitis. One other local cause is cervical carcinoma. If the cervix is bedeviled with growth, she can bleed during pregnancy. So we shall just take these causes one after the other, but we shall dwell mainly on placenta previa, placenta abruptio, and vasa previa, because these other local causes, they are things that could be managed. They could be managed separately. These are real obstetric causes of obstetric hemorrhage. Placenta previa. Placenta previa occurs when the placenta implants or is attached partially or wholly in the lower uterine segment. Placenta previa occurs when the placenta implants partially or only in the lower uterine segment. This constitutes about a third of antepartum hemorrhage. And antepartum placenta previa itself occurs in about 1% of all pregnancies. It affects about 1% of all pregnancies. The bleeding of the placenta previa results from mechanical separation of the placenta from the site of implantation, which occurs with gradual formation of the lower uterine segment, or during effacement and dilatation of the cervix at the time of labor. The bleeding of placenta previa results from mechanical separation of the placenta from the site of implantation during the formation of the lower uterine segment, or during effacement and dilatation of the cervix at the time of labor. The hemorrhage of placenta previa is inevitable or unavoidable. What is the etiology of placenta previa? The exact cause of placenta previa is unknown, but the following theories are postulated. One, the dropping down theory. What happens in this case is that the fertilized ovum drops down from the fallopian tube and is implanted in the lower uterine segment. As soon as the fertilized ovum is about to enter the uterine cavity, it just drops to the lower uterine segment and gets attached there. That's one theory. And this explains the formation of central placenta previa. And the another theory that has been postulated is the large surface area of the placenta. The large surface area of the placenta as seen in multiple pregnancy or in rhesus isoimmunization, where the placenta may encroach on the lower uterine segment because of its large surface area. So first is the dropping down theory, and then the second is the large surface area of the placenta in multiple pregnancies and pregnancies of higher orders, and in rhesus isoimmunization or in patients that smoke in pregnancy. The other theory that has been is defective decidua in the uterus. This which results in the spreading of the chorionic villi over a wide area in the uterine wall to get nourishment. Defective decidua results in spreading of the chorionic villi over a wide area in the uterine wall to get nourishment. During this process, the placenta becomes membranous and encroaches on the lower uterine segment. And the placenta may invade the underlying deciduum or mammary to cause placenta accreta, increta, or pacreta. There's what we call placenta migration theory. In about 5 to 15% of patients with placenta previa at 17 weeks, 90% of this will dissolve before 34 to 37 weeks. And this occurs because as the upper segment enlarges and the lower uterine segment forms, the distance between the lower edge of the placenta and the internal horse increases. Placenta migration. This occurs because as the upper segment enlarges and the lower uterine segment forms, the distance between the lower edge of the placenta and the internal cervical horse increases. And this phenomenon is called a placenta migration. And this will explain why majority of placenta diagnosed as placenta previa at about 20 weeks will no longer be a placenta previa in the third trimester. The lower uterine segment increases from about 0.5 centimeters at 20 weeks to about 6 to 8 centimeters at term. The lower uterine segment increases from about 0.5 centimeters at 20 weeks to 6 to 8 centimeters at term. And there is a phenomenon called trophotrophism. Trophotrophism. And this is the growth of the trophoblastic tissue towards the uterine fundus. In trophotrophism, there is the growth of the trophoblastic tissue towards the uterine fundus. And this will probably explain why people diagnosed at placenta previa before 20 weeks may no longer have a previa towards term. All patients with placenta previa diagnosed at 20 to 24 weeks should therefore have a repeat ultrasound between 32 to 34 weeks. And if at 32 weeks, if the 24 weeks ultrasound shows the placenta that covers the internal hull, cervical os, for minor amps, all patients with placenta previa diagnosed at 20 to 24 weeks should therefore have a repeat ultrasound between 32 to 34 weeks. So a rescan is always necessary if placenta previa is noted earlier, maybe around the middle trimester. So a repeat scan is also necessary to see if there is resolution of placenta previa diagnosis at that stage. What are the types of placenta previa? You can have a lateral low-lying placenta. A low-lying placenta that is referred to as type 1. In this type 1 or low-lying placenta, the lower edge of the placenta encroaches on the lower uterine segment but does not reach the internal cervical os. In type 1 or the lateral or low-lying placenta previa, the lower edge of the placenta encroaches on the lower uterine segment but does not reach the internal cervical os. In type 2 marginal, the lower edge of the placenta reaches the internal cervical os but does not extend beyond it. In type 2 of marginal placenta previa, the lower edge of the placenta reaches the internal os but does not extend beyond it. This type 2 placenta previa, or the marginal placenta previa, has two types, subdivided to type 2 placenta previa, type 2A and type 2B. Sorry, to type 2A and type 2B. Type 2A is anterior and type 2B is posterior. And the type 2B is also called the dangerous placenta previa because it may be based on ultrasound, as the fetal head may cast an acoustic shadow on the posterior placenta and in labor. Again, the posterior placenta previa may overlie the sacral promontory and therefore decreases the anteroposterior diameter of the pelvic inlet, thereby preventing engagement of the fetal head. The posterior placenta wedge between the fetal head and the sacral promontory may separate with descent of the fetal head in labor, resulting in torrential bleeding. Type 3 placenta previa. The placenta covers the internal cervical os, but does not cover the os completely. In type 3 placenta previa, the placenta covers the internal os, but does not cover it entirely. Whereas in type 4, the placenta covers the internal cervical os completely. It covers the placenta os completely. Types 1 and 2A, that is the one that encroaches the last segment, and type 2 that gets to the internal os but does not extend through it and is anterior, are called minor placenta previa. while types 2b to 4 are called major placenta previa. In fact, any type 1, any of these type placenta previa could give rise to torrential bleeding without any warning. This classification that we have just outlined has little prognostic value and does not necessarily predict bleeding patterns, as all types of placenta previa are associated with potential life-threatening hemorrhage. This classification has little prognostic value and does not necessarily predict the bleeding patterns, as all types of placenta previa are associated with potential life-threatening hemorrhage. And in this case, delivery is by cesarean section in all types. Delivery is by cesarean section in all types. Let's have a look at this diagram. You can see the placenta here. This placenta has encroached on the lower segment and it sits from some distance to the level of the internal house. This is the low-lying placenta, type 1 placenta, type 1 placenta previa. Type 1 placenta previa. Type 2. This placenta has encroached on the internal house but does not extend beyond it. This is type 2, and this is anterior. This is type 2A placenta previa. If this placenta comes here, which is posterior, say this type 2 posterior previa. This is the type 2B posterior that we said is a dangerous placenta previa that can give rise to torrential hemorrhage, that can cause non-engagement of the fetal head as a result of its decreasing the anterior-posterior inlet of the pelvis. It can be very, very dangerous, and it can cause torrential. It can shear off in labor and give rise to tertiary bleeding. And look at the type 3 placenta previa. It has gone beyond the internal house, but does not cover it completely, which is partial previa. And look at the type 4 placenta previa. The placenta covers the internal house completely. So this is a complete previa. What are the risk factors for placenta previa? Multiparity is one major problem. Multiparity. The incidence of placenta previa in nulliparous is about 0.2%, whereas in grand multiparity, the incidence has risen to about 5%. So we have very low incidence in nulliparous, which is about 0.2%. But in grand multiparity, we have an incidence of about 5%. The placenta is a fastidious organ that tends to implant on a new site with succeeding pregnancy. It's very fastidious. It tends to implant on a new site with succeeding pregnancy. Grand multiparity, a major risk factor. Advanced maternal age. This correlates too with the multiparity, and it's more common in women over 35 to 40 years. This is more common in women over 35 to 40 years. Previous uterine surgery, including cesarean section, hysterectomy, and mammectomy. The risk of placenta previa increases with the number of uterine surgeries a patient has had. Following one previous cesarean section, the risk of placenta previa is 1 to 4%, and this increases to about 10% in patients with 4 or more cesarean sections. Previous dilatation and curettage. Evacuation of the uterus. This is thought to be due to scarring of the uterus. Anatomic defects of the uterus, such as uterine septum, may also increase the risk factors for placenta previa. Uterine tumors, such as fibroids, particularly fibroids that occupy the upper uterine segment, can give rise to placenta previa. Multiple pregnancies, diabetes mellitus, smoking, rhesus immunization, and syphilitic infections are also risk factors for placenta previa. Because in these situations, multiple pregnancy, diabetes mellitus, rhesus immunization, smoking, the placentas are always very large. They are always very large. For instance, the smoking causes compensatory placenta hypertrophy, secondary to carbon monoxide, and induced hypoxemia. So smoking by itself doubles the risk of placenta previa. Whereas in multi-pregnancy and diabetic mellitus, because of the big babies, the placentas are always large and they can always easily encroach on the lower uterine segment. Then abnormal placentae, such as subcentric placenta, bilobe placenta, and placenta membranacea may also give rise to placenta previa. Previous placenta previa, yes, the risk increases in subsequent placenta previa. Previous placenta previa can also be a risk of subsequent placenta previa, and the risk increases by about 12-fold. Assisted conception probably due to implantation, probably due to multiple pregnancies, may be a good risk, or poor decidualization that may accompany assisted conception. Complications of placenta previa. There are fetal, maternal, and placenta complications that can follow placenta previa. Fetal complications. The chief fetal complication is fetal malpresentation, like breech, for instance. Fetal malpresentation. There's an increased risk of congenital anomalies, even after controlling for maternal age, in cases of placenta previa. Fetal malpresentation, increased risk of congenital anomaly. Then there could be intrauterine growth recession. Growth retardation of the fetus can be palpable. And there is a high perinatal mortality following placenta previa. And the rate of maternal mortality, perinatal mortality, can be as high as 60%. And this may follow due to the various methods applied. But the rate is falling down now. The rate of perinatal mortality in placenta previa is actually going down. It's going down now, recently, owing to conservative management, the McAfee regime that is being employed to ensure that the baby attains maturity before they are delivered, increased utilization of cesarean delivery, and improved neonatal care. All these have resulted in the low perinatal mortality that we currently experience. And it's nice to know that most mortality are due to prematurity. The maternal complications include problems that follow the hemorrhage that accompanies placenta previa, and this may lead to anemia, maternal anemia, maternal shock, preterm pre-labor rupture of membranes, and preterm labor and preterm birth as a result of bleeding episodes. Operative delivery increases because usually when the problems arises, they could pose problems to the fetus or the mother, and there may be an intention to deliver prematurely. So operative delivery increases as a result of the associated complications. Postpartum hemorrhage is another maternal complication due to inefficient retraction of the uterine segment when the placenta was implanted, as well as to secondary anemia. Postpartum hemorrhage, most of the time, may accompany the mother. Puerperal sepsis may result from operative delivery and placenta site close to the vagina. Maternal mortality is less than 1% in developed countries, but remains high in developing countries. Maternal mortality less than 1% in developed countries, but remains high in developing countries as a result of logistics in managing these patients. Then there are complications of the placenta itself that may occur. The placenta, there may be a retained placenta. There may be a retained placenta where the placenta is morbidly adherent. That the placenta may be retained. And secondly, there is a higher risk of placenta accreta in creta and pacreta. There's a higher risk of placenta accreta in creta or pacreta. When the placenta is attached to the decidua of the uterus, it's an accreta. But if it permeates into the myometrium of the placenta, it's an increta. Or if it gets to the serosa of the uterus, it's a pacreta. So you may have any of these accreta or increta or pacreta in patients with placenta previa, particularly if such a patient has had a previous surgery, previous mammectomy, previous transection, or a uterine septum in place. All these placenta complications can occur. What are the clinical features of placenta previa? Yes, usually this placenta previa presents as a painless vaginal bleeding, usually in the third trimester. It presents as a painless vaginal bleeding in the third trimester. And this differentiates placenta previa from placenta abruption. That pain, in placenta previa, you have a painless vaginal bleeding. And in placenta abruption, it's pain almost always accompany placenta abruption. And in placenta previa, the blood is typically bright red because the implantation site is close to the introitus, and so the bleeding is quickly revealed upon onset. Whereas in the abruption placenta, the bleeding is hidden, and it's dark. The bleeding itself is dark red, unlike the placenta previa where it is bright red. A third of patients with placenta previa will bleed before 30 weeks. Another third between 30 and 36 weeks. Another third after 36 weeks. So we should know that it can occur before 30 weeks, either in the second trimester, where you can make a diagnosis from bleeding. Earlier and lighter warning or sentinel bleeds predates a heavier bleed. 10% of women with placenta previa will get to term without an episode of bleeding per vagina. About 10% of them will not show symptoms, and they will get to term without bleeding episodes at all. Placenta previa can coexist with abruption placenta in about 10% of cases. Placenta previa can coexist with abruption placenta in about 10% of cases. On examination, the patient may be very pale, but the degree of pallor is proportionate to the visible blood loss. On examination, in placenta previa, The patient may be pale, but the degree of pallor may be proportionate to the visible blood loss. Again, the size of the uterus is proportionate to the gestational age. The size of the uterus is proportionate to the gestational age. The uterus is relaxed, soft, and non-tender. The uterus is relaxed, soft, and non-tender. The fetal malpresentation with a high floating head is very common. The fetal malpresentation with a high floating head is very common. And the fetal heart tone is usually present and normal in placenta previa. The fetal heart tone is usually present and normal. A speculum examination may not be contraindicated. Because we need to exclude the local causes of antepartum hemorrhage, such as cervical erosion, cervical ectropion, carcinoma of the cervix. So the speculum examination is not contraindicated to ascertain cervical dilatation and rule out local causes of APH. In any patient with APH, placenta previa must be excluded before a digital examination is carried out. You must include placenta previa in any patient that comes with antepartum haemorrhage before a vaginal examination is carried out. If one fails to do that and you do a digital examination before a speculum examination, you can easily produce torrential vaginal bleeding. How do we manage placenta previa? What is the management of placenta previa? Having made a diagnosis, something has to be done. Management depends on the gestational age at presentation, severity of the bleeding, fetal and maternal clinical conditions. Management of the placenta previa when diagnosed depends on the gestational age at presentation, the severity of the bleeding, the fetal and maternal clinical conditions. These three are very important: gestational age, severity of the bleeding, and fetal and maternal clinical conditions. If severe life-threatening and continuing hemorrhage is established, or non-reassuring fetal heart rate pattern despite resuscitation, it is expected that one should deliver immediately by cesarean section, irrespective of gestational age. In very life-threatening and continuing hemorrhage, or non-reassuring fetal heart rate pattern despite resuscitation, it's better for these patients to be delivered by cesarean section, irrespective of gestational age. If the bleeding is light, my bleeding is small in amount, is light, and gestational age is less than 37 weeks, and the mother is hemodynamically stable with no fetal distress, expectant management, McAfee of UK and Johnson of US regime is indicated. However, any patient that is greater than 34 weeks and fetal long maturity is confirmed, deliveries can take place immediately. You don't have to do a McAfee regime. No conservative management or expectant management is expected in women with developing antepartum hemorrhage after 34 weeks. And the aim of expectant management is to achieve the maximum fetal maturity possible while minimizing the risk to both mother and fetus. The overall objective being to reduce perinatal mortality while at the same time reducing maternal mortality. Again, the aim of expectant management is to achieve the maximum fetal maturity possible while minimizing the risk to both mother and fetus. The overall objective being to reduce perinatal mortality while at the same time reducing maternal mortality. What are the components of McAfee or expectant regimen? Hospitalization. Patient is hospitalized for bed rest and observation till when the baby is matured. In a hospital with capacity for emergency cesarean section on a 24-hour basis, functional and efficient blood banking services with blood readily available at any time, as well as neonatal backup. So, patients must be hospitalized in a hospital where cesarean section can be done at any time within 24 hours, and with a functional and efficient blood banking services with blood readily available at any time, as well as neonatal backup. That's the first component of the McAfee regime. And in facilities with no capacity for personalized nursing care, as in most hospitals in the top tropics, patients should preferably be nursed on a bed close to the nursing station. But as a matter of fact, in this circumstance, patients should be referred to a hospital where cesarean section can be done. Patients should have at least 2 liters of intravenous fluids for resuscitation by our bedside. Should have at least 2 liters of intravenous fluids for resuscitation at our bedsides. And it might be necessary to establish intravenous access with a wide bore cannula. It might be necessary to establish an intravenous access with a wide bore cannula. For non-sensitized resource isomination negative women, might be a need to administer anti-D hemoglobin, irrespective of whether routine antenatal prophylactic has been administered, and at least 500 international units of anti-D immunoglobulin is appropriate for all sensitizing events after 20 weeks. We may be able to transfuse if the packed cell volume is low, or we might administer hematinics to maintain patient's hemoglobin concentration at least 10 grams per deciliter. There may be a need to transfuse if the packed cell volume is less than 30%, or at least administer hematinics to maintain patient's hemoglobin concentration at least above 10 grams per deciliter. If the pregnancy is less than 34 weeks, there may be a need to administer corticosteroids for fetal lung maturity. There may be a need to administer corticosteroids for fetal lung maturity if that pregnancy is less than 34 weeks, because delivery can take place. Another bleeding can take place anytime, and there may be a need for immediate delivery. So corticosteroids for fetal lung maturity is important. Again, to prevent uterine contractions that may lead to premature delivery, there may be a need to tocolize, to give some degree of tocolytics. Because if uterine contractions continue, it may disrupt the placental attachment and aggravate bleeding. Uterine contractions can disrupt the placenta attachment and aggravate the bleeding. So usually a need for tocolytics. But one has to be careful on the type of tocolysis that has to be given. This is because in the presence of the vaginal bleeding and uterine contractions, placental abruption, which contraindicates tocolysis, cannot be excluded. Yes, because in the presence of vaginal bleeding and uterine contractions, placental abruption, which contraindicates tocolysis, cannot be excluded. So one has to be careful on the type of tocolysis that you may use. Where tocolysis is considered, tocolytics with less maternal cardiovascular side effects should be used. In this regard, beta mimetics like terbutaline and Ritodrine should not be used because the tachycardia is a common side effect to this drug. Indomethacin is also contraindicated as it inhibits the COS1 and COS2 inhibits platelets COS1 and COS2, thereby worsening bleeding. Nifedipine also has been associated with cases of maternal hypertension and is only best avoided. Magnesium sulfate is recommended and is also useful for fetal neuroprotection. Magnesium sulfate. So we have to look at very safe tocolytics. So Tabutalin, Ritodrine, Indomethacin, and Nifedipine are not very good tocolytics to use in placenta previa as a component of McAfee regime. If magnesium sulfate is highly recommended and is also useful for fetal neuroprotection. Fetal monitoring must be adequate. You check fetal heart tones at least twice daily cardiotachograph, and twice weekly fetal biophysical profile. 3 weekly ultrasound for fetal growth and placenta allocation. For placenta allocation is very important. The mother should keep a perineal pad from which we can monitor continuous bleeding, vaginal bleeding. The urinary output also should be maintained at least 30 ml per hour. You need to look at the urinary output, which should be at least 30, ensure that the woman is making at least 30 ml per hour. Thromboprophylaxis in the form of adequate hydration and compression ossuary is recommended. But need for anticoagulation should be assessed and individualized. Need for anticoagulation should be assessed and individualized. McAfee regime should be terminated at 37 weeks gestation if there is pre-labor rupture of membranes with uterine contractions, signs of fetal distress, torrential bleeding, onset of labor or uterine fetal death. As I said earlier, anytime from 34 weeks, if a pregnancy at 34 weeks, that patient will not require a McAfee regime, where there is a good neonatal backup and there is capacity for cesarean section 24 hours. Cesarean section for placenta previa. Cesarean section for placenta previa. One needs to consider the following. 1, the choice of anesthesia. The choice of anesthesia. If life-threatening hemorrhage, if there is life-threatening hemorrhage, where maternal and fetal conditions are compromised, general anesthesia is recommended to expedite delivery. Otherwise, regional anesthesia is safe. Combined spinal and epidural anesthesia may be preferable for longer surgery. So one needs to consider the choice of anesthesia. Yes, 2, skin incision. Skin incision, subumbilical midline incision is indicated if a previous scar has been done for a major placenta previa or so, or for any surgery at all. Otherwise, a financing incision may be adequate. Financing incision is adequate. But in a life-threatening condition, a subumbilical midline incision may be preferable. It's faster and there is less blood loss compared to financing incision. The uterine incision. If the lower uterine segment is poorly formed, it's always better to do a classical incision in the body, in the upper segment. Your incision may be 2/3 in the body of the segment and 1/3 in the lower uterine segment. That would be a fine something. But if the lower segment has been well formed, a transverse incision will be preferable. Clinical incision, if the lower uterine segment is poorly formed or extremely vascular, so you can do a classical incision or a lower segment transverse incision if if the lower uterine segment has been well formed, or there is no much of vessels in the lower uterine segment. Delivery of the fetus. Yes, if the placenta is anterior, the placenta should just be displaced laterally to reach the fetal membranes and rupture the membranes and deliver the fetus. But if you have to cut through the placenta, that may give rise to exsanguination of the fetus, because there will be a lot of bleeding, and within a fraction of seconds, a lot of bleeding may be lost that could compromise that fetus. So it's better to displace the placenta laterally to allow easy delivery of the fetus, rather than cutting through the placenta, which may exsanguinate the fetus. Placenta side bleeding following delivery. This is also a common complication of surgery, bleeding from the site of the placenta. Yes, and one needs a good skill to be able to manage this complication. Oversewing bleeding sinuses with atraumatic suture may be necessary. You can oversew the place, and if that oversewing does not stop the bleeding, then one can use intramyometrial injection of prostaglandin F2 after, or a beach lynch brace sutures, or if possible, use a uterine artery embolization. But rarely you may use uterine artery, internal iliac artery ligation, or even hysterectomy as a last resort. That's if the bleeding becomes too much. But management of the third stage is very important. The use of carbetocin these days has relieved many physicians of the problem of excessive bleeding at the time of cesarean section. Once the placenta is out, right, carbetocin or cytometrin can actually stop the hemorrhage, can actually stop the hemorrhage. Placenta previa after previous lower uterine segment. Placenta previa after previous lower segment cesarean section. It's very important that consultant obstetrician plans and directly supervise delivery. It's also important that consultant obstetric anesthetist plan and directly supervises anesthesia at delivery. The blood and blood products must be available on site, and there's a need for multidisciplinary involvement in pre-operative planning. Consent includes possible interventions such as hysterectomy, leaving placenta in situ, cell salvage and interventional radiology must be discussed with the patient. And local availability of level 2 critical care bed that high intensive care unit care requirement must be detailed, must be available. So that ends the topic of placenta previa as a major cause of antepartum hemorrhage. I would say it constitutes about 3 to 5% of antepartum hemorrhage, and it's responsible for about 1% of all pregnancies. The next cause of antepartum hemorrhage is placenta abruptio. Placenta abruption. Placenta abruptio is a partial or complete separation of a normally situated placenta after the age of fetal viability, but prior to the delivery of the fetus. Unlike abruptio placenta is placenta implanted in the lower uterine segment, but abruptio placenta, the placenta is normally situated in the body of the uterus. So separation of this placenta that is normally situated after 28 weeks is called abruptio placenta. Abrasive placenta accounts for a third of cases of antepartum hemorrhage and also affects about 1% of pregnancies. But it affects about 0.6 to 0.9% of pregnancies, approximately 1% of pregnancies. The hemorrhage in placenta abrasio is accidental. The hemorrhage in placenta abrasio is accidental, and bleeding is almost always maternal. Bleeding is almost always maternal. Unlike the bleeding in placenta previa, the bleeding is from the placenta site and is bright red, and the bleeding in abrasio is dark red. Placenta abrasio could be revealed or concealed or a mist type. Abrasio placenta could be revealed, concealed, or a mist type. In revealed abrasio, which is the most common type, separation of the placenta, the blood tracks down between the membranes and uterine wall to escape through the cervix and is visible externally. The blood in revealed type, the bleeding is revealed externally through the cervical horse. Unlike the concealed type, which occurs in about 5 to 10% of cases, the hemorrhage is trapped between the placenta and the uterus and not visible externally. Whereas in the mixed type, the mixed abrasio placenta, in this type, some of the blood is concealed and some revealed. So it's a mixed type. So we have a revealed and concealed abrasio. Classification of placenta abrasion. Classification. We'll talk about two types of classification. What called Shear's classification. In grade 1 of this is a retrospective diagnosis. Grade 1 retrospective diagnosis. There are no symptoms. There is no symptoms. At delivery of the baby, you have a retroplacental clot at the bed of the placenta. Shear's classification. The grade 1, the first type, retrospective diagnosis made after delivery. Just the finding of a retroplacental clot around the placenta at delivery. In grade 2, there are classical features of abrasio placenta. In grade 2, classical features of abrasio placenta. There is external uterine bleeding, there is tense abdomen and tender abdomen with fetus alive. That's grade 2. There is classical features of abrasio placenta. There is external uterine bleeding. The uterus is tense and tender abdomen, but the fetus is still alive. In grade 3, the fetus is dead. We have grade 3A. Grade 3A, dead fetus without coagulopathy. Grade 3A, dead fetus without coagulopathy. And in grade 3B, we have dead fetus with coagulopathy. Unlike the Shear's classification, it almost correlates well with Page's classification. Grade 0, there is a retrospective diagnosis. Our grade 1 in Shear's classification is retrospective diagnosis, where there is retroplacental clots around the placenta bed after delivery. Grade 1 in Page's classification is external uterine bleeding, uterine tenderness, and no fetal distress. In grade 3, there is fetal distress or high intrauterine fetal death. And grade 3, there is maternal shock with or without disseminated intravascular coagulation. So, you find out both the Shear's classification and the Page's classification are almost the same. But Shear's classification is better, is mostly applied in most cases. It's straightforward. You can easily make a diagnosis you can easily classify whether it's grade 1, grade 2, or grade 3. Grade 3A or grade 3B, with or without coagulopathy. What are the risk factors for placenta abruption? What are the risk factors for placenta? One is previous history of abruption placenta. If a woman has had an abruption placenta before, the risk increases by almost 5 to 10% in the next pregnancy. So one has to take a very good history to be able to predict abruption placenta, because the recurrence risk is between 5 to 17% and 19 to 25% after 2 abruptions. 2, increasing parity. Increasing parity is another risk factor for abruption placenta. The incidence in primary gravida is about 1% and 2.5% in gram multiparous. Increasing parity. Incidence in primary gravida is about 1% and 2.5% in grand multiparous. This, however, may be due to defective desudalization after the implantation of multiple pars placentas on the uterine wall. Advanced maternal age, above age 30, advanced maternal age. This still correlates with increasing parity, because the higher the age, the more exposure to pregnancy. But usually, advanced maternal age may be due to hypertension, and multiparity as well with maternal age. Abdominal trauma. Abdominal trauma is a strong risk factor, both accidental and resulting from domestic violence, fight between husband and wife, or accident involving road traffic accidents, or a street fight may result to abruption placenta. Polyhydramnios, from rapid decompression of the uterus and following rupture of fetal membrane, is a major risk factor. Polyhydramnios. So one has to be careful. You must suspect the risk of placenta abruption if you have to do something about polyhydramnios, like artificial rupture of membranes at the time of delivery. So suspect there may be a placenta abruption. Pre-labor rupture of membranes. Pre-labor rupture of membranes is also a very big risk factor. About 2 to 5% of pregnancies complicated by preterm pre-rupture of membranes will also be complicated by placenta abruption. The risk is further increased if chorioamnionitis complicates premature rupture of membrane. Multiple pregnancies. In multiple pregnancies, we have 3-fold increase due to rapid uterine decompression after delivery of the first fetus. Multiple pregnancies, 3-fold increase from rapid uterine decompression after delivery of the first fetus. Acquired or inherited thrombophilaxis is one. Then maternal hypertension. Maternal hypertension. All hypertensive disorder of pregnancy are risk factors. All hypertensive disorder of pregnancy are risk factors to placenta abruption. Be it preeclampsia or eclampsia, they are risk factors to placenta abruption. Smoking. Smoking doubles the risk of placenta abruption. Risk is further increased if combined with maternal hypertension. Illicit drug use of cocaine and amphetamines in pregnancy, alcohol use in pregnancy, short umbilical cord, uterine fibroids, especially if fetal placenta, and things like folic acid deficiencies may result in placenta abruption. Clinical features of placenta abruption. Clinical features. We've talked about the risk factors, listing all these risk factors. So you may have to take history. A good history will start from the maternal age, the parity, the presence of hypertension, smoking, drug usage like cocaine, amphetamines, and all the rest. All these things you have to obtain from the history. So in many cases, because we know that they may be asymptomatic and diagnosis made retrospectively after delivery of the placenta. They may be asymptomatic and diagnosis may be made retrospectively after delivery of the placenta. But 80% of patients will present with complaint of their vaginal bleeding. 80% will come with complaint of vaginal bleeding. And the bleeding is painful. often related to maternal hypertension or trauma, and blood is dark colored, compared to that of placenta previa, which is painless and is a bright red. A placenta previa is not associated with maternal hypertension or trauma. Maternal pallor or shock out of proportion with visible blood loss in concealed or mixed type is very common. A woman may just lose about 20 to 50 ml of blood and she goes into shock with abruptio placenta. Height of uterus may be disproportionately larger than expected for gestational age in conceived type because of the distension of the bleeding, and the bleeding into the myometrium can cause enlargement of the uterus. The uterus is always tense, rigid, and tender, making it difficult to palpate fetal parts. The uterus is tense, rigid, tender, making it difficult to palpate fetal parts. Unlike the uterus and placenta previa, the uterus is of normal size, correlates well with gestational age, is soft, but in abruptio is rigid, is tense, rigid, and tender, making it difficult to palpate fetal parts. Compared to placenta previa, fetal presentation is normal, with evidence of fetal distress 50% or demise in 15%. Yes, compared to placenta previa, fetal presentation is normal, with evidence of fetal distress 50% or fetal death, like the third that shares classification in the third level, where you can have fetal death with coagulopathy or without coagulopathy, or fetal death with coagulopathy. The liquor in abruptio placenta is blood stained. The liquor in abruptio placenta is blood stained following rupture of membranes. Cuvulae uterus, uteroplacenta, what we call uteroplacenta apoplexy, cuvulae uterus. In concealed, it's very common in concealed abruptio placenta. In this cuvulae uterus, there is massive intravasation of blood into the myometrium up to this uterine serosa, which results in a purplish, bluish, or copper red indurated uterus seen at laparotomy. Cuvulae uterus seldom interferes with uterine contractions sufficiently to cause severe PPH, and is therefore not an indication for hysterectomy. Note that in cuvulae uterus, there is massive intravasation of blood into the myometrium up to the uterine serosa. Making the uterus to look purplish, bluish, or copper red at laparotomy, and it may interfere with uterine contractions and cause severe postpartum hemorrhage. This is a classical description of the cuvulae. This is a classical description of the cuvulae uterus. You can see purplish area, bluish area, and see how distended the whole uterus looks like. You can see the appearance. In this type, all this, with the tense nature, the solid nature, filled with blood in the myometrium, this is a classical cuvulae uterus seen at cesarean section, and it's a major cause of postpartum hemorrhage. It's a major cause of postpartum hemorrhage. Ultrasound finding in abruptio placenta. Ultrasound finding in abruptio placenta. In the early phase of placental abruption, the area of hemorrhage will appear isoechoic or hyperechoic compared with the echogenicity of the placenta. The area in the early stage, the area of hemorrhage will appear isoechoic or hyperechoic compared with the echogenicity of the placenta. The hematoma becomes hypoechoic within a week and sonolucent within 2 weeks, because at that time the bleeding must have stopped, must have been absorbed from the placenta bed. So you expect within 2 weeks it might become sonolucent. Actually, in a very type 1 that that is discovered retrospectively. Management of abrosive placenta. Management depends on maternal and fetal clinical conditions, associated complications, and gestational age. In abrosive placenta, there is no room for conservative management like abrosive placenta. There is no room for extreme conservative management like we have in placenta previa. For many reasons, the hemodynamic status of the mother should be immediately assessed and stabilization done if necessary. The obstetrician should not be falsely reassured by a normal blood pressure and pulse, as the patient may have had hypertension previously and has had too rapid a volume loss to produce tachycardia. So the normal blood pressure should not deceive you, or a normal pulse. Establish intravenous access with 2 wide-bore cannula and send blood samples for a complete blood count, coagulation screen, group and cross-match at least 4 units of blood, and electrolytes and urea and creatinine must be done. If blood transfusion is required, commence intravenous fluid resuscitation while awaiting blood for transfusion. Maintain hemoglobin concentration at greater than 10 grams per deciliter and urine output at greater than 30 ml per hour. Fresh frozen plasma may be administered if fibrinogen level is less than 100 milligrams per deciliter, and platelets if the platelet count is less than 20,000 millimeter cubed. Yes, for RhD negative women, administer anti-D hemoglobin, about 500 milli-international units. Administer it, and then the mode and timing of delivery depends on the severity of the placenta abruption and gestational age. If the fetus is dead, induce labor and deliver vaginally. If the fetus is dead and there is evidence of coagulopathy, please induce labor and deliver vaginally. Early amniotomy is recommended, as this might hasten labor progress and reduce uterine bleeding. Amniotomy helps to reduce the tendency towards consumption coagulopathy by eliminating the chance of release of thromboplastin to the circulation. Early amniotomy may also help prevent the complication of covalent uterus. Early amniotomy may also help prevent the complication of covalent uterus. If the fetus is alive but distressed despite adequate resuscitation and the cervix is not fully dilated, deliver by emergency C-section. If the cervix is fully dilated, do instrumental vaginal delivery to hasten the delivery of the fetus. If there are no signs of maternal or fetal distress, bleeding is minimal, and gestational age is 37 weeks or more, induction augmentation of labor with continuous fetal monitoring can be done, but it's always better in a very good climb to do an emergency C-section. Induction of labor may waste time and may lead to further morbidity of the fetus. In preterm fetuses, it's better to do a cesarean section. From 32 weeks, the baby's weight will be more than 1 kilogram, and this baby can survive. But in some climb, with preterm fetus that is not in distress, expectant management may be done, but we need a very close fetal monitoring. As I said, if baby is less than 34 weeks, there may be still a place in your expectant management to administer corticosteroids for fetal lung maturity, and within 24 to 48 hours, effect delivery of the fetus. So again, we have just finished the abrosio, a course of antepartum haemorrhage abrosio placenta, and I expect that you should be able to know when to deliver immediately or when to do a conservative expectant management, which I say is very controversial. Unlike antepartum, unlike placenta previa, there is no good room for conservative management in abrasive placenta because it can quickly, the bleeding can be more torrential, and the outcome of the fetus, the outcome for both fetus and mother may be worse in abrasive placenta when compared to placenta previa. And last, let us look at vasa previa. Vasa previa briefly. In fetal previa, unlike in abrasive placenta, the bleeding, we say the bleeding is maternal. And in placenta previa, the bleeding is from the placenta bed. But in vasa previa, the bleeding is from the fetus. Note that in vasa previa, the bleeding is from the fetus. The fetal vessels, let me say, in about 1 to 2% of single-T pregnancies, the umbilical cord inserts into the fetal membranes, so-called velamentous cord insertion. In about 1 to 2% of single-T pregnancies, the umbilical cord inserts into the fetal membranes, so-called velamentous cord insertion. So therefore, in vasa previa, the bleeding that is coming out of the vagina is from the insertion of the umbilical cord into the fetal membranes. It's insertion of the umbilical cord into the fetal membranes. So the bleeding is directly from the fetus. The fetal vessels which run on the membranes in the lower uterine segment, crossing over the internal cervical horse in front of the fetal head, has a vascular connection to the placenta, traversing. So that bleeding that comes out of the horse from that velamentous cord insertion is the vasa previa. In both cases, look at this diagram. Look at this diagram. Look at the placenta here. Look at the cord, the umbilical cord, gets inserted through this membrane, the velamentous membrane. And you can see that this cord passes through the internal cervical horse. So along this area, on this velamentous insertion, there could be a rupture of these vessels, or the vessels there, and it can bleed and come out through the cervix and come out through the vagina. Fetal mortality rate in vasa previa is about 50%. Why? Because you need a high index of substitution to make a diagnosis. You need a high index of substitution to make a diagnosis. Most people will miss the diagnosis of vasa previa. They'll be treating placenta previa, not knowing that it's bleeding from the velamentous insertion of the umbilical cord. As I said earlier, it complicates about 1 in 1,000 to 500 pregnancies. It complicates about 1 to 1,000 to 5,000 pregnancies. The classic triad is painless vaginal bleeding, just like we have in previa. But in this case, where the fetal heart rate in placenta previa is normal, we have fetal heart rate abnormalities following rupture of the fetal membranes. So, two classical things to diagnose vasa previa is a painless vaginal bleeding with a fetal heart rate abnormalities. The classical painless vaginal bleeding and fetal heart rate abnormalities following rupture of fetal membranes. So you cannot miss that diagnosis of vasa previa. painless vaginal bleeding, fetal heart rate abnormalities following rupture of fetal membranes. Fetal heart rate abnormalities seen include an initial reflex tachycardia, following loss of intravascular volume, and this is usually followed by bradycardia and with severe anemia in sinusoidal fetal heart rate pattern. So initial tachycardia followed by bradycardia, and usually the delivery is by emergency cesarean section. Delivery is what? By emergency cesarean section. How do you make a diagnosis of vasa previa? From the history, painless vaginal bleeding, fetal heart rate abnormalities following rupture of fetal membrane. Number one. So, ultrasound finding of either velamentous cord insertion or sensorineural lobe of the placenta is one of the greatest diagnoses. Then the color Doppler ultrasound can clearly identify fetal vessels coursing through the fetal membranes, like I've shown you in the diagram earlier. Yes, what called single alkali denaturation, single alkali denaturation, Ogita and Lodeslot tests are useful in identifying fetal hemoglobin in bloody vaginal fluid. So, in conclusion, the three major antepartum hemorrhage are placenta previa, abruptio placenta, vasa previa, and all this can worsen the outlook of the maternal and parental morbidity and mortality. And the most common causes of APH, as listed, and prompt diagnosis and efficient multidisciplinary management of APH will avert adverse maternal and perinatal outcome. So I thank you for listening.